Hi guys, I'm Sarah. I'm one of the interns, and today I'm going to be doing a basic overview of EV blocks. So to get started, we'll talk about a case. We have a 68-year-old male. He has a past medical history of hypertension, diabetes, and hyperlipidemia. He's coming in today because starting this morning, he had palpitations and chest discomfort. On review of systems, he had some lightheadedness that has now been resolving since he's been in the ED. Denies chest pain, dyspnea, no nausea, vomiting, or diaphoresis. Vitals are listed below. BP of 152/82. His heart rate 55. Respiratory rate of 18. He's statting 99 on room air, and he's currently afebrile at 96. So here's our patient's EKG. Harry, do you want to try to interpret this for us? Thanks, man.
All right. So heart rate around like in the 40s, Jewish. Rhythm, like a block. And they're not congruent with each other. So it's like the access is normal access. No ST elevations.
Good. All right, so at the end of the presentation, we're going to go through this EKG together, okay? Good job. All right. So first, to start off my talk, I'm going to just review the normal conduction pathway because I think we should just review normal before we talk about anything abnormal. I'll go over first degree block, and then type 1 and type 2 of second degree. We'll talk about third degree, and then as I just mentioned, we're going to go back to the case and review the EKG and dispo for this patient. And then I've got some practice EKGs at the end if we have time. Okay. So the normal conduction for the heart. So electrical activity is supposed to start from the SA node. This is the dominant pacemaker of the heart. The SA node causes contraction of the atria, which is noted by the P wave. From there, there's a slight conduction delay in the AV node, which is represented by the PR here. And then from that, the electrical activity goes down the bundle of His through the right and left bundles of ventricles, causing ventricular depolarization, which is the QRS complex. And then the T wave is the repolarization of the ventricles. And of note, the atrial repolarization is hidden within the QRS complex. So if the SA node is what's driving the pacing of the heart, the rate should be between 60 to 100 beats per minute. In normal sinus rhythm, you're going to have a P wave before every QRS, as well as a QRS following every P wave. Normal intervals, so the normal PR interval is between 120 to 200 milliseconds, which should be about one large box on the EKG. And narrow QRS complex is less than 120 milliseconds, so that's like 3 or 4 small boxes. And QTC, so the upper limit of normal for men is like 440, and for females it's 460, so that corresponds to basically 2 large boxes. So in this strip, does anybody just want to comment on what they think about like the rate, if it's a sinus rhythm or not, and about the intervals? Okay, if not, that's fine. So here, looking at the rate looks to be about 70 beats per minute. And the question is if it's sinus. So here I'm seeing P waves before every QRS complex, and I'm seeing a QRS after every P wave. So this is sinus to me. Looking at the intervals, so the PR interval actually looks a little bit prolonged. It's longer than one large box on the EKG. We have a narrow QRS complex, and the QTC interval looks okay. So this is an example of a first degree AV block. So the key features of a first degree AV block is you're going to have a PR interval greater than 200 milliseconds. That's the box on the EKG. And you typically have a narrow QRS complex. So basically what a first degree block is there's just a prolonged conduction delay at the AV node. And this is actually a normal variance of about 2% of the population, but it can also be caused by increased vagal tone, so it can be seen in some athletes. It can also be caused by like digoxin toxicity, and inferior MI, myocarditis, or Lyme disease, just in causes. If you see this in the ED, there's no intervention that's needed. Just note that you should probably be avoiding blocking agents in these patients, so calcium channel blockers, the blockers, and yeah. Okay. So here's the next strip. So the rate on this one, it's a little bit hard to determine because I can't say if this is a 10-second strip or not. So I'm just going to jump to talk about the rhythm. So to determine if it's sinus, I see a P wave for every QRS complex, but there's not a QRS complex after every P wave, as you know here. There's a P wave without a QRS complex. Next, I'm going to look at my intervals. So QRS is narrow, and then looking at my PR intervals, this one looks normal. This one looks a little bit prolonged, and then here we have a dropping of the QRS complex, which is a non-conductive wave. So if you guys probably can predict, this is a second-degree block, and it is a Movitz type 1. So key features of this is you have progressive lengthening of the PR interval with intermittent non-conductive waves, so that's the drops QRS. And then you have a narrow QRS complex. Okay. So causes of this, so acute inferior MIs can cause this, as well as rheumatic fever, increased vagal tone again in athletes, if the patient's on AV nodal blocking agents, myocarditis, post-cardiac surgery. So if the patient's asymptomatic, there doesn't need to be any treatment for this, but in some cases, the patient can be symptomatic. So if the patient is symptomatic, you can use atropine to help, and the way you administer this is it's 0.5 milligram IV push, and you can give that every 3 to 5 minutes, up until the desired heart rate you want, or until you reach a max of 3 milligrams. And any patient, even if it's type 1, if they're symptomatic, they deserve a cardiology consultation. Okay. Next shift, again, difficult to determine the rate on this because I don't know if it's 10 seconds or not. But looking at the morphology of the QRS complex, it's narrow. I have P waves before every QRS, but I don't have a QRS after every P wave, so it's not sinus. And looking at my intervals, unlike the previous one, the PR interval looks stable. It's not changing with each beat. So this is characteristic of a type 2 block, second degree. So key features, you can have intermittent non-conducting P waves with a fixed PR interval. You can actually have a wide or a narrow QRS complex. So in this case, this is a narrow QRS complex, and that means the level of block is happening above the bundle of His, usually in the AV node. And the reason it's still narrow is because when the block is the level of the AV node, the electrical conduction is still following normal conduction pathways. If your block is below the bundle of His, depolarization of the ventricle takes longer because it's not following the normal conduction pathways. So causes of this, it's usually caused by damage or dysfunction of the infranodal conducting system, and that includes anterior MI, such as infarcts, idiopathic fibrosis of the conducting system, which is known as Lebb's disease. If the patient had cardiac surgery, inflammatory conditions such as rheumatic fever and Lyme disease, autoimmune conditions like lupus. You can also see it in hemochromatosis, sarcoidosis, hyperkalemia, and again, AV nodal blocking drugs. And management of this, if your patient is asymptomatic with a type 2 block, you should just put transcutaneous pads on them regardless, because patients with this type of block have a high rate of converting to complete heart block. If the patient is symptomatic, and especially if it's a narrow QRS complex, you can try giving atropine the way I mentioned before. Atropine works by blocking vagal stimulation, so if the block is coming from the level of the AV node, it should be effective. If the patient's unstable and you need time to get to pacing, you can also give epinephrine in order to bridge them so you're able to transcutaneously pace them. If they don't respond to transcutaneous pacing, you move on to transvenous pacing, and again, this needs cardiology consult and admission. So here are some additional examples of a type 2 block. So this is a 4-to-1 conduction block where we have 4 atrial beats, and then you have 1 QRS. And this is a narrow example QRS, and then here we have a variable block where you have a wide QRS. Okay, next. This is actually pretty regular, so we can look at the rate here. So looking at the ventricular rate, it looks to be about 40. And then I'm looking at the atrial rate here, and that looks to be about at 100. So there isn't really any association between the atrial contractions and the ventricular contractions. And here we have a wide QRS complex. So this is an example of a third-degree complete heart block. So key features of this is there's no AV conduction, so the P waves are not associated with the QRS complexes. Again, you can have a wide or narrow QRS, and these patients have a high risk of sudden cardiac death. I just want to mention that if the block is at the level of an AV node, it's actually called a junctional escape rhythm. And pacing at this level, that pacemaker usually has it's 40 to 60 beats per minute. If the ventricles are pacing the heart, it's usually a heart rate below 30. Okay. And causes of this are similar to the same causes that I mentioned in type 2, where there's damage to the conducting system. If a patient is stable, you can treat it the same as Mobitz type 2 block. If these patients are unstable, they need to be transcutaneously paced until a transvenous can be placed. Most patients with type 3 block are going to need a permanent pacemaker. There's a few cases where, like if it's caused by Lyme disease, Lyme infection, they can recover. Or if it's caused by AV nodal blocking agents, then removing those agents can sometimes help them recover, but most of the time patients are going to need permanent pacers. And again, cardiology consult and admission. Okay. So Harry, let's go back to this EKG. You mentioned the rate. So what would you say the rate is for the ventricles here? Yeah, like this one's, it might be hard to see, but like, so this one's on one of the lines. And you like had it before.
What is it?
So it's around 45. Yeah, and that's basically what you said before. But if you actually look at the atrial rate, so here's a P wave, here's a P wave, there's another P wave. It looks like there's one buried here in the QRS complex. So the rate of the atria is beating at about 90 beats per minute. Okay. And would you say this is sinus or no? Is there a P wave before every QRS complex?
Yes.
Okay. Is there a QRS after every P wave? No. Right. Okay. Good. And we actually can't really see a PR interval here because there's no association between the P waves and the QRS complex. And is this narrow or wide QRS? Narrow. Good. So as you said before, this is a third-degree AV block, and this would be a junctional escape rhythm. Okay, because it's a narrow QRS complex, and it's about 45 beats per minute. So management just spoke for this patient. So if you remember the vital signs earlier, this patient wasn't actually hemodynamically unstable, but the patient would get transcutaneous pads placed on them in case they did need to be paced, and they are going to need cardiology consult and admission. Okay, so if I'm like running out of time here, but there is one practice EKG I do want to go over. Does anybody want to try this one? If any, it might be hard to see, I'm sorry. Assuming that this is a 10-second strip, what do we think the rate is here? Mm-hmm. Good, great. And is this sinus? I see Madonna shaking her head. No, it's not. Why is it not sinus? Exactly. So this poor guy over here is alone without a QRS complex. Same with this one, and this one, and this one. So what about the intervals? What do we think about the PR interval? They look fixed, right? So what do we think? What do we think this rhythm is? Right. So here's the thing. I thought that too, but this is actually untypable. So this isn't Mobitz type. We can't say if this is Mobitz type 1 or type 2. And the reason we can't say that and why I wanted to go over this EKG, because this was something I learned while making this presentation, is that in order to tell what type it is, you need consecutive P waves. So we can't tell if this is actually fixed because you have a conducting P wave and then a non-conducting P wave. So we don't know if it would have marched. We don't know if it would have stayed fixed. So in some cases, ways you can potentially tell, if this was a YQRS complex, most likely it would be a type 2. But if you see a patient like this in the ED, even if they are completely stable and they're asymptomatic, you can't rule out that this is not a type 2 block. So you would need to manage it as it's a type 2 block. So they warrant a cardiology at admission.
These are all type 2s. You just can't say, if they're second-degree blocks, you just can't say if it's type 1 or type 2. So you just assume it like you said. But you just always assume the worst.
Right. Okay. So in summary, first degree block, PR interval is fixed, greater than 200 milliseconds. No intervention needed, just avoid AV nodal blocking agents. Second degree block, type 1, you'll have lengthening of the PR interval with intermittent non-conductive P waves. If your patient is asymptomatic, no big deal, don't worry about it. If they are symptomatic, they're going to need probably admission and cardiology consult. Type 2, fixed PR interval with a drop QRS. Again, they're going to need admission and a cardiology consult. If it's a 2-to-1 block and you don't see 2 PR intervals consecutive, treat it as if it's a type 2 second degree block. Assume north, just like Dr. Silver said. And a type 3 or third degree AV block, there's no association between the P and the QRS complex. These patients are going to need to be admitted. They're symptomatic, you can treat with atropine or epinephrine until you're able to pace them. And most of the time, these patients are going to need pacemakers. Any questions?
That was a great review of blocks. Just remember 2 words, rhythm strip. All patients you think have any sort of block, just get a rhythm strip. Because remember, you're just seeing a very small window, but the rhythm strip, you can see it, you can print out like 3 or 4 pages, you just have them run it for a few seconds, and it really can help you delineate out a significant block from a non-significant block. And sometimes the cases are obvious, but sometimes they're a lot more subtle, like telling the difference between a type 1 and type 2 secondary block is the difference between discharge and admission and getting a pacemaker. So it's a huge difference. And so really delineating out is really important. And rhythm strip is really the key. Anytime you see anybody with any sort of questionable rhythm, just have the PCA do a rhythm strip, which is basically they just attach the EKG leads and they just hit rhythm strip. And instead of seeing an EKG, you just see, usually you'll get a whole bunch of leads that you can choose them. And then, lead 2 is the most useful. But
any other questions? Okay, cool. Also, all of these EKGs that I didn't get to go through, I stole them from Dr. Silverberg's website. He has an EKG website for physicians that I only found out about like 1 shift with him. So if you guys get a chance, some of them are kind of nifty and they were helpful.
website.
All right, thanks guys.